Good evening, ladies and gentlemen. Thank you for all coming this evening to celebrate the Best of Bristol. So the Best of Bristol series aims to provide students with an opportunity to learn about subjects that aren't within their primary academic discipline, and to really celebrate the university's excellent teaching staff. This year, we asked students to tell us who were their most engaging and inspiring lecturers. Therefore, on behalf of all of the Best of Bristol team, we're really excited to have Professor Emma Robinson with us here this evening. As I'm sure you're all aware, Emma Robinson is Professor of Psychopharmacology here, and she's particularly interested in the cause and treatment of psychiatric conditions. I've had the privilege of being taught second-year pharmacology by Professor Robinson, and her talks were always really interesting. And indeed, I can assure you that there was always a disproportionately high number of students at Professor Robinson's 9 a.m.s than any other lecture series. This evening, Professor Robinson will explore the history of antidepressants and will consider new research avenues that can treat mood disorders. Further comprehension of this field is really vital to the health of our societies. So, without further ado, I invite Professor Robinson to begin. Thank you.
Well, thank you very much for that kind introduction. I can't believe that that's the turnout. What other people must be getting at their 9 o'clock. Anyway, it's a great privilege to be here tonight, and for you, thank you for giving up your time to come and hear me talk. I think I have a really easy job at the University of Bristol. I'm a professor of psychopharmacology. I talk about drugs in the brain, which are, to me, just such engaging topics. And in fact, I think a lot of people have an interest in the brain, and a lot of people are interested in how drugs affect the brain. So what I'm going to do tonight is I'm going to talk about a topic that is of particular interest to me. It's an area that breaches both my teaching but also my research field. And I'm going to try and cover in the 40 minutes I've got a little bit about the backgrounds and history around antidepressant treatment, but I'm also going to talk about some of our recent research. And the topic is particularly relevant because some of you may be aware that on the 4th of March, the FDA licensed a new antidepressant. This is the first new class of antidepressant to come out in 30 years. And in fact, it's a breakthrough in terms of psychiatric disorders. We haven't really seen any big new development in the drug treatments of these disorders. So I'm going to tell you a little bit about that. And in particular, I'm going to talk about some of the challenges that we still face, but also the opportunities that I believe our understanding of drugs of abuse may bring to treating depression. So I'm sure many of you are aware, but I think it's really important to reiterate the severity of the disorder that we are dealing with. Major depressive disorder is considered to be a 21st century epidemic. It certainly has its biggest effect in modern society, as we see more and more development within our culture, then we also see an increase in the prevalence of major depressive disorder. It's identified by the World Health Organization at the moment of globally affecting somewhere in the region of 300 million people. My passion for studying this topic comes from the fact that it affects young people. Once people develop depression, the likelihood is that they will suffer to some extent a relapsing, remitting disorder for the whole of their life, and that can be a very long time when people will suffer. It's also the leading cause of disability-adjusted life years. So this is the time that we suffer with a burden such as a health burden. The other thing that's really worrying people is the increasing prevalence we're seeing in young people. And so undoubtedly, this is a disorder that we need to try to understand. However, it's not easy. The brain is not easy to study at the best of times, and studying disorders, particularly psychiatric disorders, is really difficult. So we really have very limited knowledge about the cause of major depressive disorder. I remember going to my first British Association for Psychopharmacology meeting, and somebody put their hand up and asked a question of a speaker and said, "So what does cause depression?" And this person went, "I've no idea." And everyone around the room, "We've no idea." And I thought, wow, nobody knows, how exciting. But still, we really don't know what causes depression. It's an incredibly challenging disorder to study. We also have this problem where we're actually always playing catch-up. It's true for all psychiatric disorders. We actually don't really know how current treatments work. It's all about serendipity. So people have tried out lots of different things. In the early part of medicine, many were quite unethical, but some things worked, and then people have carried on developing those. And then we kind of try to retrospectively go back and work out how they work. So we're kind of still in a bit of a circular argument. So we have quite a limited understanding of how psychological and pharmacological treatments work, and I'll talk a little bit more about that. And then, of course, we have the problem that at the moment, some patients fail to respond to treatment. So it's estimated about 30% of patients don't respond to treatment. We also have a major issue, and that is that current conventional antidepressants, I could say this up until earlier this month, there is now, of course, a new rapidly acting antidepressant, but up until then, they all had a delayed onset. Now, the problem was that what we're talking is a period of 4 to 6 weeks. So you give someone a medication, so they come into you, you diagnose depression, you give them a medication, and you say to them, these pills are going to make you feel a bit weird, you're going to get some side effects, but by the way, you're not going to feel any better. In fact, you're not going to feel any better probably for about 4 weeks. After 4 weeks, if you still don't feel any better, then we're going to change to a different medication, and then hopefully that one might work. And there are many patients who will describe a cycle where they keep going back and no, they still haven't got efficacy, they still, and trying another medication and another medication. So really, really challenging issues for the clinician. And with about 30% of patients getting to the end of going through the range of drugs and still not having an effective treatment. So I'm going to talk a bit about the history of the treatment. I find this quite interesting. The early history, it was seen as a spiritual disorder which was linked to demons and evil spirits. It wasn't really until Hippocrates described a disorder of melancholia that really probably the disease we recognize as depression was really well described. However, this, of course, was put down to a cause of excessive of black bile in the spleen. It was the 17th century that probably was when we started to see a link between depression and some of the psychological causes that we now know today are very strong risk factors. So things like poverty, fear, anxiety, and loneliness. However, we didn't really have any progress in terms of treatments. The 18th and 19th century saw some really interesting approaches to treating mood disorders. So water immersion, spinning people on a stool to induce dizziness, which was thought to put the brain back into the correct position. So it was thought that in depression, the brain had got out of alignment in some way. And if you spun people really, really quick, you could put it back together. An interesting treatment that was developed at that time was electroconvulsive shock therapy, which of course is still used today. So for treatment-resistant patients, there is a treatment which involves putting them under general anesthetic and inducing a grand mal seizure, so actually inducing a seizure in the brain. And it is effective. The reason it's still used today is because it is effective. It's actually very effective in some patients who've previously been drug resistant. Another option at the time then was vomiting. That's no longer a recommended treatment. It wasn't until the 60s, so it was the 1960s when we saw really what we would recognize as modern psychiatric treatment. And this was at a time when both pharmacology, so the use of drugs to treat mood disorders, and psychological treatments developed. And there were two kind of key areas. One, the psychological, was that a psychologist, Aaron Beck, came up with this hypothesis that the processes that led to depression were all around negative thinking, so that individuals developed almost like a habit of this negative processing. And so what people focused on was the self, so they would become very much focused on their own negativity. I'm ugly, I'm worthless, I'm a failure. The world around them, so they saw the world as somewhere that nobody really cared about them, and also they could see no benefit, nothing in the future. And so people became very entrenched in these negative thoughts. But at that time, and I would say even today, psychology and pharmacology tend to sit themselves quite far apart. And I hope that as part of today's lecture, I'm going to help you think about maybe bringing those closer together. The pharmacological treatments were discovered completely by chance. As it happened, there was lots of chemists playing around with making compounds. They were trying to make sedatives. They were trying to make new treatments for tuberculosis, for various infectious diseases. And what happened is, as a side, they tried out some of these drugs in patients who had the clinical condition they were aiming to treat. And being good scientists, they made the interesting observation. They noticed that their mood changed. And they took that opportunity and they went, well, I tell you what, let's see what happens if we try it in these people with mood disorders. And the first publication was on this compound, imipramine hydrochloride. We still use it today. And it was tested in patients. Until now, only electroconvulsive shock therapy for endogenous depression had been available. And this was a completely new revolution. This was a pill, something that you could give people. And it was shown to be quite effective. And so, to put that into perspective, this is where these sit, the first generation antidepressants. The evolution of pharmacological treatments is quite interesting. Since, well, throughout human history, humans have been very good at using substances to alter their minds. Not always for medicinal reasons, in fact, many cases for non-medicinal reasons. But people soon understood that things like alcohol, the opiates, could have calming, sedating effects. And people were using these drugs to treat anxiety, depression-like disorders. Then in the early 20th century, this is when you see the revolution in chemistry and lots of new compounds being synthesized, and we saw things like the sedative hypnotics. One of the very first treatments for intractable neuroses was to give an intravenous injection of a sedative hypnotic, and there were reports that this was effective at bringing people out of their intractable neuroses. And in fact, I hope we might revisit this when we think about ketamine and what ketamine might be doing. And in fact, have we really made a big step, or are we just going back to a slightly more refined version of what was happening here? Of course, the big breakthrough was these first-generation antidepressants. They were shown to have specific effects on mood, and they really were. There was really good evidence that these drugs were able to, in a decent proportion of patients, to alter mood. The problem was that these drugs were not very clean in terms of their pharmacology. They interact with lots of things in the brain, and they did things like cause sedation, they caused blurred vision, dry mouth. A psychiatrist colleague of mine said, have you ever tried a tricyclic antidepressant? I said, no, I haven't. They said, oh, they're pretty revolting. They do make you feel a bit unpleasant. And so they weren't easy, but the biggest problem was toxicity. So these drugs are cardiotoxic. So relatively low number of pills is needed for someone to overdose. And if you imagine depression, suicide risk, giving people a medication that carries the ability to commit suicide, there were very large numbers of patients using these medications to take their own life. And it's not good tricyclic antidepressant overdose. It's a very dangerous form of overdose. It's very difficult to treat. And so what pharmacology achieved, and I think we mustn't underestimate what pharmacology achieved. There can be a little bit of negative feeling around antidepressants, and particularly things like the SSRI antidepressants, but actually they really were a major step, because what happened is people doing a lot of psychopharmacology worked out which aspects of imipramine were underlying the mood effects and which aspects of imipramine were linked to side effects and toxicity. And then clever chemists came up with a way of designing novel molecules that could pull these things apart. And from that came our second generation antidepressants. These achieved specific effects on mood, but they had far reduced side effect profiles and, most importantly, dramatically improved safety. So they were a lot safer medications. So this was great. However, many of the issues still remained. Delayed onset of action. They didn't help that treatment-resistant population. There were still people who weren't responding. And on the 4th of March 2019, which really is very recently, we saw this compound. It's actually S-ketamine. It's one of the isomers of ketamine, has been licensed for the treatment of treatment-resistant depression. I'm going to talk mostly about this in a moment, but it's a very exciting compound because it has a rapid onset of action. And when we say rapid, we mean rapid. 40 minutes after patients have been given an intravenous infusion of this drug, they feel completely better. So it's very exciting. However, let's go back to the conventional antidepressants. And I just want to sort of give you a little bit of an insight into some of the mechanistic aspects. And I hope it'll link through to the end where I talk a bit more about how we hypothesize these things may be coming together. So conventional antidepressants is different examples of the second generation antidepressants that are widely prescribed today. They work on synapses. So their target is actually here within the synapse, where neurons communicate with each other, so the electrical signal becomes a chemical signal, and then it interacts with these postsynaptic proteins to propagate and continue the passage of information. And antidepressants interact here. They're not very selective, they just boost the signal. They're a general boost to the signal. And it's been quite easy for us to work out which proteins they interact with, what their chemical effects are. The challenge we've had is trying to explain how this chemical effect leads to people reporting that they feel better. And we don't have the answer to that yet. But we do have hypotheses, we have theories. And one of the exciting things about having clinically effective compounds is that you can start to try and close this loop. So you can use clinically effective compounds. We study, a lot of our studies are in animal models, and we try to look and understand how are these drugs working in the brain, what are they doing? And then can we use that to explain? And two key theories have come out of this. One was the monoamine hypothesis. Why? Because it turns out that all the effective antidepressants worked on at least one of these chemical transmitters. So the monoamines are a small group of transmitters. They're actually modulators. They act to refine the function of the brain. And the hypothesis was relatively straightforward. The deficit in monoamines caused people to become depressed. The drugs boost monoamines in the synapse, and that reverses the symptoms of depression. So that was one of the ideas. The problem was that it didn't really account for the delay. Because actually, if you measure chemically what happens, these drugs work straight away. So if the drug works straight away, why does the person not immediately say they feel better? And so this mismatch led to, and has been behind probably some 50 years of research, trying to explain. And the hypothesis that's come out most strongly has been one called the neurotrophic hypothesis. So this is the idea that actually being stressed and all the things that cause depression, they lead to your brain getting smaller. And we can see that. We can scan the brains of patients with depression, and we can see that their brains are smaller. And then if you study in animals what happens at the level of the individual neurons, you can actually see that when you give an antidepressant drug, it slowly causes the brain to regrow and regenerate. And so the neurotrophic hypothesis came out. And this has really been a very strong case. And why this matters, why does it matter? Why it matters is because if you want to make better treatments, you need to try to understand which processes you want to interfere with. So that's why we all want to study and understand the mechanisms. So this is the kind of model we've been working with around delayed onset, and it's been around for a long time. So the idea is that any risk factor for getting depressed, so that is stress, early life adversity, there's many risk factors that we know cause depression, and they don't cause them acutely. You can have a bad day and you don't get depressed. What happens is when those things are chronic, when they happen for a sustained period of time, and we think that that leads to maladaptive changes in the brain. It's a nice broad, I don't really know what they are, but we'll call them maladaptive changes, and that makes people depressed. The symptoms, the psychological symptoms, I feel sad all the time, I've lost interest in the activities I used to enjoy, these kind of symptoms. And then to explain how our antidepressant treatments work, and I've brought psychology back into here. I'm a great fan of both aspects of this. So the idea is that antidepressants increase synaptic concentrations of the monoamine. This leads to, again, a rather broad statement, beneficial adaptive changes in the brain. So slowly, the brain starts to adapt and reverse these maladaptive changes, and symptoms start to improve. Now, if you look at a clinical case, that's exactly the sort of thing you can see. Patients seem to have slowly developed the disorder, and then they seem to slowly get better. There's always been a little bit of we've ignored that psychological treatments work as well, because how does that work? So Beck's always said that psychological treatments work slowly, because what you do is you train people to think more positively. And then slowly, those positive ways of thinking start to infiltrate into their learning, their memory, their behavior, and slowly they start to get better. So that was good. Biochemicals. So again, how does this work? Well, antidepressant drugs have an immediate biochemical effect, but they slowly induce changes, adaptive changes in the brain. So whilst they kind of sat separately, we could sort of call them top-down and bottom-up. That was what we used to say. So psychology is top-down. The cognitive parts of the brain help adapt the subcortical parts of the brain and make you slowly become more positive and overcome symptoms, whereas the biochemical is coming the other way. You change the chemistry, and then that feeds forward to change the psychology. And what we've all been trying to do is, can we achieve this more quickly? Anyway, everything's kind of been slightly thrown in the spanner, got thrown in the works when ketamine came on the scene. Because up until now, delayed onset and what you're looking at here all suggested that it was a slow process. People slowly got depressed, so they would have to slowly get better. Maybe we should just accept that. And then somebody thought it was a good idea to give patients intravenous ketamine, and they did. And they saw the most profound effects. So this is depression scores. These are placebo, these are depression. Basically, they get better. And the time course here, this is 40 minutes, and then here we're seeing 24 hours. And the surprising thing was they give these guys a single dose of ketamine, just one infusion, and for up to 7 days, patients are feeling better. They do get a little bit of a dissociative effect, so the drug of abuse part of it does come through, but only for a very short period of time. And importantly, this is gone before you see the effects on the mood symptoms. And I think probably the most exciting finding in terms of how we deal with mental health conditions, this is suicidal ideation. So 40 minutes after being given an intravenous infusion of ketamine, somebody with high levels of suicidal ideation, they are gone. They no longer are experiencing those mood symptoms. So how does ketamine work? Well, of course, the neurotrophic camp that was working on the neurotrophic hypothesis and had been saying everything's really slow, it takes, because your brain takes a long time to regenerate itself, doesn't it? It's a slow process. So they were rather stunned when this anesthetic, I mean, ketamine is an anesthetic, a painkiller. It's a dissociative drug of abuse. It has a really short pharmacological effect, but it was having this long, sustained effect in patients. So Duman, who's based in America, and his colleagues focused very much on trying to show that this was interacting with neurotrophic processes, and they did. They have beautiful data from animal studies showing that actually what ketamine is doing is instantly stimulating the brain to make new synapses. One of the elements that we think is about the growth and the communication within the brain. I'm afraid I'm not quite believing of this idea, as people in my lab will know. I'm more interested in a different model that was coming out before ketamine, actually. A group in Oxford and our own group were working on this idea that maybe we should bring psychology and biology together. And maybe there was a bit more about how drugs change the chemical environment such that the brain learns in a different way. And maybe we could explain delayed onset. Maybe we could actually also explain the effects of ketamine by thinking about it in this slightly different way. And that's what we've been doing. And so what we actually, Catherine Harmer's group have been focusing on this idea of a neuropsychological mechanism. The idea that when you're depressed, you have these biased thoughts. So you experience the same world as other people, but you've developed a biased memory of that. It's negatively biased. You see things in a negative light. What we've shown is that ketamine, immediately, 1 hour later, gets rid of them. This is all animal work. We give animals negatively biased memories, and then we block them with ketamine. And then very recently, this is unpublished, exciting new finding, I don't understand it completely yet either, we turned a bad memory into a good memory. And no, I've no idea, but I think it's really exciting. And what's really exciting is that, you know, if this is how ketamine is working over this very short timescale, then it brings this idea that there is a neuropsychological mechanism. There's an interaction between thought processes, learning, memory, and how these drugs chemically change the brain. And it's not just ketamine as a drug of abuse that's exciting. There are many other drugs of abuse that, as it happens, appear to have rapid onset antidepressant effects. I'm sure many of you will be aware of psilocybin. It's the active component of magic mushrooms, very much seen as a compound, a drug of abuse. However, the FDA has now approved a fast-track trial to look at whether this is an effective treatment for depression. So this company has begun a clinical trial, and they're particularly looking at psilocybin as an adjunct to psychotherapy. So they're looking at the fact that if you use a chemical to change the environment of the brain and then combine that with psychotherapy, maybe you can make it work better. Obviously, this isn't actually that new, because in the 70s, LSD was being used in a really similar way. The advantage of psilocybin over LSD is psilocybin is a much safer compound than LSD. And then I'm intrigued by this compound. I really didn't know much about it. I mean, scopolamine to me is a compound I used as a pharmacology student when I was doing gut bath experiments to block muscarinic receptors, and that was it. It wasn't really that exciting. And then I find out it's called devil's breath. It's used for all sorts of crimes. Apparently people walk up to you and blow this powder on you, and then you can't remember anything and you'll do anything. But it also turns out that it's antidepressant. Why am I interested? Well, it's affecting memory, isn't it? If that's what it's doing, maybe, so it comes back to this idea that maybe modifying memory in some acute way has an antidepressant effect. Okay, so why is it exciting? So ketamine, I think, and why I think drugs of abuse, and coming back to the title of this lecture, is because I think it helps us perhaps bring together a novel hypothesis about the cause and treatment of major depressive disorder. And if I'm right, that has really important implications for how we move forward. So we can bring this together into a kind of two different ideas. So if we think about conventional antidepressants, they have a delayed onset, and that we think maybe about new learning. So the brain, these drugs, they set up the brain for more positive cognitive processing, but you have to go and experience things for them to work. The brain can only, these conventional antidepressants only work by modifying what's coming in. They only modify new learning, and that takes time. You've got to build up a bank of new positively biased memories before you yourself, your mood, your perception of your mood changes. And it fits really nicely with Beck's idea of negative thinking. How does ketamine work? Well, we think that ketamine works in a very different way, because what we think is that ketamine has a unique ability to block and modify what's gone before. People who abuse ketamine will tell you that what they really find that they like about it is it takes them away from the past and puts them in the here and now. It seems to take away those kind of prior concerns and prior memories. And so maybe that's what's happening, and that's what our data look like. So maybe we can block these previously learned and negatively biased memories, bringing people very quickly back to a sort of reset, as it were. So what are the implications? Well, the implications are that conventional antidepressants require new learning, and that means that if we want to make them work effectively, we need to see engagement. People take the drugs, but they need to re-engage with society, the environment, and rewarding activities. And we kind of have some evidence that that's true, because people who have depression but are in very good socially supported networks do much better than those that are socially isolated. We also think that ketamine modifies these previously learned biased memories, and that may be why it's rapid, but it's not sustained. So ketamine is not perfect. Ketamine certainly has rapid onset antidepressant effects. It's very exciting. It's a breakthrough, I think, in terms of knowledge about major depression. The most exciting thing is it tells people their mood can get better quickly. What we now need to do, though, is understand that, because ketamine is a drug of abuse. And there are huge concerns about the fact that this may well end up increasing its abuse. And whilst the medical use of ketamine under controlled conditions is relatively safe, it's low dose, if people then decide to abuse ketamine at higher doses, then that's very, very different. There's risks of brain toxicity, and there's also a bladder cystitis, which is caused by one of its metabolites, and that's a really nasty, nasty disorder. The other thing is it's actually not a complete miracle. It's short-lived. It's effective, but it's short-lived. There are side effects. And actually the stigma, I'm sure many of you be aware, people still, they'll go to their GP and be diagnosed with depression, and they'll say, well, we'd like to put you on antidepressant. I don't want to go on antidepressant. They're addictive. I don't want anything to do with them. And there are many GPs who will report that their patients just refuse to engage with therapy, and they're suffering because of it. Okay, so I'm going to try to fairly quickly just run through how I think, very briefly, we can start to try to get somewhere and improve what we've got. So can studies in animals provide a better version of ketamine? If we understand how ketamine works, then ideally we can then make better antidepressants. I'm going to come back to one of my early slides where I think ketamine is like the tricyclic antidepressants. It's not perfect. There's lots wrong with it. But it's a starting point. It's a revolutionary new achievement in terms of medicine, but we've got to improve on it. So like we use the TCAs to help us make the SSRIs, what's ketamine going to help us make? And that's what my research is about. Patients are really hard to work with, ethically, practically. However, if you want to move into animals, you have another problem, and that is, how do you study emotional behavior in animals? They don't lie on couches and tell you their problems, and studying emotional behavior is really quite challenging. So this is just, I'm going to tell you a very short part of the work that we've done, and what we've done is we've tried to take a new, so up until the work I've developed and the work we've been doing, there's really been very little in terms of the ways we look at emotional and animal. They've been pretty crude measures, effective in terms of developing SSRIs, but not really up to the job of what we now need. So what we've done is we've taken a simple idea. Patients with depression attribute less value to positive experiences. We know that, we can observe that. That's a well-established fact. So that we call an affective bias. So you don't learn a piece of information as an absolute piece of information. You learn a piece of information and it's biased by your emotions. So very happy people have a positive bias, depressed people have a negative bias on those experiences. And we can do exactly this in rats. So rats are very good at learning things. Rats are particularly good at learning how to find food in bowls. So they look, and one of these, so these, that video involves two different digging substrates. One has food in, one doesn't. Rats very good at learning their foraging task. So what we do is we give two independent learning experiences. They're both positive. They both involve finding a food reward. But under one experience, the rat learns it under control conditions, and the other one, we manipulate its affective state. And then we say to the rat, at the end of the training, which do you prefer? Now, if we're right, then animals should be able to learn under equal emotional states, so neutral, and when we ask them, there should be no bias. So they're equal value rewards, the animal's effective state was identical, so there should be no bias. If we are right, then a negative bias should mean that although the absolute value was identical, when you ask the rat, they're going to show a preference for the experience that was under neutral conditions. So there'll be a negative bias. And vice versa for positive. And this slide is about 3 students' PhDs worth of data, so I must acknowledge that there's an awful lot of work goes into developing this, and it all looks rather simple when I put it on this slide. So basically, this is how you prove you're right. So we take our rat model, and we first of all test it with absolute reward. So we give you 2 pellets on one day, 1 pellet the next day, can you learn? And the rats are brilliant at it. They remember which substrate had 2 in it, and rats really do count. They know 2 pellets over 1. And so we get a positive bias during the choice test. Always good to do controls. All good scientists must do controls. And there's our control, neutral, neutral. The assay works. But what's really exciting is that a whole range of antidepressants we've tested cause a positive bias. This is no difference in reward value. They are identical. The two experiences should look like this. The only difference is that before one of the experiences, we gave them a single dose of antidepressants. So we've proved that we can bias new learning in a positive direction with an antidepressant. Not just that, we can do it with social play. So we like a bit of cognitive therapy for rats. How do you do psychological therapy for rats? Well, you take them and you put them in an arena with all their friends for 8 hours and they get to have a big play session. And it works. It causes a positive bias. The other thing is we can do it the opposite way. We can give treatments that we know are risk factors for depression and they cause negative biases. And that includes a psychosocial stress. That's a bad day for a rat. That's 10 minutes in a small box followed by the rest of the day on your own. And they don't like it, and it causes a negative bias. We also have gone on, and this is a load of data crammed into a short space of time, but we've gone on to think about, how does this link into ketamine's neuropsychological effect? This is the headline. What we've got is a dissociation. So this neuropsychological mechanism beautifully dissociates between conventional and rapid onset antidepressants. So what we show is that biases associated with new learning are modified by conventional antidepressants, but not ketamine. And this involves a very important part of the brain, the amygdala, which is very important in emotional learning. However, recalls, so how biases associated with recall are modified, is completely the opposite. Conventional antidepressants have no effect. Once a memory is biased, your conventional antidepressant can do nothing. However, ketamine can block it. So why is this really exciting? Well, it's exciting because it might explain delayed onset. It might explain the relationship that exists between why ketamine has a rapid effect, but it isn't sustained, and why conventional antidepressants have a delayed effect, but it takes time for them to have to work. And the other thing that I find really exciting is that it's very specific. So this is not that ketamine, so the problem with giving a rat ketamine is maybe he's just forgotten who he is, what he is, and doesn't really care. And maybe that's the same with depressed people. Maybe you just give them ketamine and they just don't care for a bit. But actually, that's not what the data suggests. It suggests that low-dose ketamine has a very specific ability to modulate affective bias. This is a bias that was induced by 2 pellets versus 1. Exactly the same protocol. Give ketamine, absolutely no effect. Ketamine does not modify absolute information. What it modifies is bias. Okay, so I think the exciting thing about drugs of abuse and what we're learning about depression is that it's enabling us to start to integrate my favorite topics, the biological and the psychological processes in major depressive disorders. We're not sitting with them in separate parts and separate camps. We're being able to integrate them. It's important because we think it shows that conventional antidepressants modify new learning, but not previously acquired biased memories. That's why they have a delayed onset. And I think one of the most important things we can do is give depressed patients an insight into how their drugs may or may not work so that they actually can use that knowledge. And if we can prove this, which we're starting to, then we can roll that out. Conventional antidepressants and psychological treatments are slow because they have to slowly shift mood through these more positive changes in new learning. But they also need new experiences. If people take their pills and do nothing, then the chances are, if these data are right, that the drugs can't do anything either. And maybe that's one of the critical parts of treatment resistant. Rapid onset, very exciting because they block affective biases, but they don't seem to modify new learning. So maybe they're rapid, but they're short term. And maybe that's the thing. Maybe we can start to bring these together. But certainly what we've shown is ketamine has a specific effect on biases. Okay, so just, can I have a few more minutes? Yep. So what can we achieve with new animal models? Well, I think we have the opportunity now to develop better treatments with rapid and sustained effects. Because we've dissected the biology, can we now find compounds that will help us bring that back together? We can also look for more effective use of current treatments. I'm a great fan in thinking about, in believing that actually what we've got isn't that terrible. It does work for some patients. So can we now work with that to try to make those work better? better integration of pharmacological and psychological treatments. And I thought I would just finish off with a couple of slightly more light-hearted elements of what we do. There's been a really interesting debate out in the literature about depression, and I'm sure you've heard about it. It's about exercise. So I'm sure most of you believe exercise is antidepressant. Yes? That'd be true? Well, actually, the clinical data is not very clear-cut. So when you take a clinical trial and you take depressed patients, you give them a personal trainer, you send them to the gym every day for an hour, and they work with the data don't come out very positively. Some studies do, but a lot of studies don't. So we thought, let's find out. So let's use a simple model. Is exercise in rats antidepressant? So what we did is we gave rats a personal trainer. This was one of my PhD students who trained rats to run on a treadmill. So they were trained for a week to learn to run on the treadmill, which they duly do, and we gave them a short period of exercise as one manipulation and compared that to home cage. So this is the same task I was describing before. This time, though, we're comparing, does it put you in a positive affective state going on the treadmill, or do you prefer just to be allowed to be at home? Well, the answer is, well, exercise may be antidepressant, but only if you like it. So what we find is that some of our rats, quite clearly, quite enjoyed it. So they don't mind a bit of forced exercise. By the way, rats are, by their nature, very lazy. So these data are exactly what I would expect to see. The majority really didn't enjoy the experience. So being forced to exercise, if you don't like it, may not be antidepressant. The other thing we also asked is tickling pleasurable for rats? The exciting thing about having a task where you can really ask about affective state in animals is that you can have a bit of fun with it as well. And so there's been a bit of a debate about tickling. So if you tickle rats, so you actually use your hands to play with the rat gives out high-frequency vocalizations, which is akin to laughter. And laughter in the animal kingdom is actually really rare. There's very few species that show it. So humans, primates, are really the only ones. And there's been a bit of a debate, do rats actually laugh, and is it pleasurable? So again, these are some unpublished data, but I find them really quite exciting because yes, but not all rats like to be tickled. So just like the human population, yes, overall tickling does induce a positive bias in rats, but there is a perfect correlation. I mean, you don't get as good correlations as this in our studies very often, but there is a perfect correlation between affective state, so how much they show a positive bias, and how much they laughed. And in fact, this guy over here, I believe it's this rat over here. So this is the rat that found it such fun that when you put him in the bucket where he was going to be tickled, he gave anticipatory laughter. Whereas the little guy down here was the one who kind of sat there and didn't say anything because he really wasn't too keen on the experience. Okay, and so with that, I will say thank you very much for your attention.
Thank you. So thank you very much, Professor Robinson. We'll now open up the floor to questions. So please raise your hands and we'll come bring the mic to you. So.
Hello. Do you think it would be possible for someone to overcome a chronic addiction to antidepressants?
So I think there's a lot of debate really about antidepressants being addictive. I mean, I think in reality there's no evidence that the drug itself is addictive. I think the problem is that people become very fearful of stopping antidepressants because of the symptoms returning, and that's a very reasonable fear to have. In that way, it then means people feel very dependent on continuing to take their medication. I think with careful input from clinicians and psychologists, it should be possible to slowly reduce the dose of the antidepressant, which is what's recommended, slowly reducing the dose of the antidepressant. If people still are able to then feel well, then they can gain confidence in the fact that they don't need the antidepressant in order to stay well. But there really isn't evidence of a directly reinforcing effect of antidepressant drugs, the sort of the classic SSRIs. Quite different with ketamine. Ketamine is a known drug of abuse.
Great, thank you. Any more questions?
Thank you. You mentioned earlier about humans being hard to study, naturally, and I wonder whether, because in psychiatry, where diagnoses are culturally determined and experiences naturally subjective, is research hindered by existing diagnostic frameworks?
Yes, brilliant question, absolutely. And so one of the things we've done a lot of work on is working with our clinical colleagues to say to them, look, I can never ask a rat how it feels. I just can't. It's never going to happen. But you can use similar tasks to the types of tasks we use in your patients. And in fact, we're not the only ones who've been saying this. So we talk about subjective versus objective measures of emotional behaviour. And there's been quite a lot of development in that area in clinical research as well. Some really beautiful data. So Catherine Harmer's group in Oxford, particularly, I would say, that they've really pioneered this. So they look at things like emotional processing. So we show people emotional faces. We look at activity in the amygdala. We also are able to ask people, how do you categorize these emotional faces? Do you see them as happy, sad? And if you give people ambiguous faces, then depressed people will more often than not see them as sad or a negative emotion, whereas normal people will see them as a positive emotion. And that's a really clear, objective measure. Now, interestingly, her work showed that antidepressant drugs acutely modify those, which fits very much with this idea that, yes, there are changes that happen immediately in the brain with these drugs, particularly in a relevant area, an objective measure of emotion, but it takes time before people subjectively feel better. And I think you're absolutely right. We need to see a big shift in the way we diagnose and we carry out clinical trials into psychiatric disorders.
Perfect, thank you. Do we have any more questions? Great. I'll go to you first, and then if you're able to pass it down. Thank you.
Thank you. I was just wondering, do any of the mentioned neurotreatments have any anxiolytic effects so as to treat both depressive disorder and generalized anxiety disorder simultaneously?
Yeah, so all antidepressant drugs are effective at treating anxiety. So the tricyclic antidepressants were always used. They're called antidepressants, but actually they've always been a treatment for anxiety. And in fact, because other treatments, so the benzodiazepine type of compounds, there's always been a concern about the dependence liability of those. So they are addictive. They're quite addictive, and people also have to take more, and then they experience risks of withdrawal. So actually, it's always been psychiatrist's choice to try to use, if somebody has generalized anxiety and needs a long-term treatment, then a tricyclic antidepressant, and then of course more recently the SSRIs. And in fact the SSRIs have been trialed and are licensed specifically for different anxiety disorders. So yes, they are effective. And ketamine has effects on anxiety symptoms as well. The two are very, very closely linked. There are aspects of symptoms that are different, but there is a very close relationship between them.
When the FDA goes about allowing a drug of abuse to be used for medical purposes, how do they go about deciding whether or not it's a good idea to put more of a drug that's been used for rather maybe bad purposes into the public? Like, what if that just makes it even much of a bigger problem? Because if you just...
I mean, it's a huge concern, and everybody's talking about it. If you read the newspapers, the literature, the scientific literature, that is exactly what everyone's talking about. The FDA, so it's a really interesting set of trials, because actually they weren't that effective. So it was only 2 out of 5 trials that were positive, which is very unusual for the FDA to then be so unanimously in favour. But what the FDA said is that they took on board the reports of the patients, that there were treatment-resistant patients who were describing their illness, 5 years of total and utter black misery, doom, and this drug had worked for them. And they saw that as a big opportunity. The other thing is that it's not unusual to have a medicine that's addictive. Heroin, morphine, these are very commonly used painkillers. Yes, there are risks of abuse, but we kind of know that, and we know that they exist. I'm not saying we have the perfect solution to managing that, but we are, it's not uncommon for that to be something that happens in medicine. I do think there is a lot of concern that ketamine will be available. I'm sure it will come into the UK in the not too distant future. There are private ketamine clinics now. The worry is that what people do is they turn to street ketamine because they think that they can treat themselves, and then you get dose. If you're taking a higher dose of ketamine, there is a high risk of damaging the brain, and certainly if people repeatedly take high doses, then there's this risk of this ulcerative cystitis, which is incredibly painful, unpleasant condition. And I think it's going to be about education. It's about making sure that information's out there and monitoring it. I was talking to a colleague who's been working at Bristol Drugs Project, and they're saying that actually they're already aware of people effectively self-medicating with these. So maybe, I'm going to have a positive view on this. I think that, yes, there is a risk, but maybe it'll bring that risk to the fore, and we'll actually start to deal with it, because a lot of drug addiction is linked to mental health problems, and so maybe it'll be a good thing, and it'll help us, look at this in a more open way.
We've just got time for a final few questions. I saw you just popped your hand back up.
On the FDA again, is it common practice for them to see a pattern of the general public abusing a certain type of drug and then decide to look into whether or not it would help with psychological disorders?
I don't know. I really don't know. I mean, certainly this ketamine has come through a very typical drug development type of pathway. So it was a preclinical study, it was an animal study. Many years ago, somebody tested ketamine. They saw a really interesting effect in a fairly crude model, but in a model of depression. They compared it with another drug that acts through a similar mechanism, showed that they were dissociable, that they were different, and then went, well, that's quite interesting. Because ketamine is already widely used as an anesthetic and a painkiller, it's on the World Health Organization's list of, must-have drugs. It was easy to get a trial. It wasn't difficult to take it to that next stage of clinical trial, and then from there. So it's followed a fairly standard route through with pretty good evidence, right the way through. And the important thing is ketamine is a really safe drug if used in the clinical way. And so, but it's very different when it's abused and when it's taken at much higher doses. But I don't think the FDA, I don't know, but I don't think that's the route the FDA's taken for this. I think if we, drugs of abuse have the same drugs of abuse have been used for a very long time. What I'm saying is I hope that now we are thinking about this, we might see actually a little bit more acknowledgement that mental health and addiction go together.
Okay, we've just got time for 2 more questions, so...
Would it be possible for people to take ketamine to tide them over until the previous drugs kicked in, like after the 6 weeks?
Yeah, so all the trials that have been done, people have stayed on a conventional antidepressant. So they've been on a conventional antidepressant and then they've been given the ketamine in addition. So that's how it's being used. Ketamine at the moment is recommended, I think it's no more than twice weekly. So it's not a daily drug, it's not an oral pill. You have to go into hospital, intravenous injection, or the new one that's been licensed is a nasal spray, but it's still going to be delivered in hospital because people are going to be dissociated by the drug for a short period of time. So you're going to have to be in hospital for two hours at least. And I think that's the hope, is that it will kick-start the system into more positive processing, whatever is behind that, and then enable the conventional antidepressants to then have their effect. So I think that is what people are hoping is going to happen. I'm going to have a slight note of caution because one of the things that we're concerned about is whether or not actually ketamine, if ketamine is used too frequently, whether it actually will modify positive learning as well. So what will happen is you might pull people into the neutral zone, but are you going to actually make them happy and positive? And we don't know enough yet, but I think it's important. It's going to be important to study the interaction between ketamine and conventional antidepressants in these psychological models, and we haven't done that yet.
Perfect. Is there a final question? Oh, sorry, somebody else.
Some research has found when ketamine is used in a low dose for pain relief that there were adverse effects, so dysphoria, hallucinations, but also aggravation. So would that not have a counter effect if it was used for people with depression?
I don't know the dose that you're referring to. I know that certainly when ketamine is used in trauma, so when it's used in with accident and emergency type of situations, the dose is very much higher than is being used here. And certainly people experience dysphoria, they experience feeling very weird, they have very vivid hallucinations. It's why it stopped. It used to be used as an anaesthetic in particularly things like dental surgery, where you wanted something really safe that you could anaesthetise somebody with. A nice injectable, nice and easy to use, but it stopped being used because people felt so awful coming round from it. But that's at a much higher dose. I think the importance of dose here is going to be key. The dose that's being used here is very, very much lower. I mean, it's certainly, I can't think of the human doses for anaesthesia, but in the work we do with the animal, we're talking 100-fold less of the drug to be antidepressant. So I don't know if that is the right answer to your question, but certainly, as far as I'm aware, at the very low dose, you don't get the really hallucinations and you get a short period of dissociation and then recovery.
All right, well, I think our time's up, and thank you very much, Emma Robinson, for this really compelling lecture. So we give a big round of applause.